So good morning. Good morning, and today our lecture will be dedicated to surgeries on bones on joints. So in the planet is the fourth lecture. Yes, I told you the previous time, but in reality, now it is our fifth lecture in topographic anatomy. So yes, what is a fracture? First of all, we have to know. Fracture is a damage of a continuity of the bone. So it doesn't matter if the bone is broken in the middle, like it is divided into two parts, or maybe it's just a fracture somewhere in the epiphysis. Yes, small part, lateral part was separated from another bone. Anyway, it is a fracture. And fractures are the most common in the long bones, such as femur, humerus, bones of the forearm, and the leg. So what are the absolute signs of a fracture? First, when patient comes to us and he complains of pain, yes, so pain, of course, is the first sign of a fracture. We should identify what is it exactly, if it is a fracture or maybe just it is a small trauma. Maybe it is dislocation, something. So absolute signs of a fracture, they are crepitation. What is crepitation? It is a special sound when one end of the bone touches another end of the bone. There is bony crepitation, which we can see in the fracture, and there is also ear crepitation, when we have discussed it as a previous lecture. When gas entered subcutaneous fatty tissue, we also feel the same sound. It is crepitation. Then deformity of the limb. So definitely a limb will be deformed, will change its shape, and it is also one of the signs of the fracture. Certainly, I want to mention that this is a sign of a fracture with a displacement. If there is no displacement, then it's fine. Like there will be no deformity. Shortening of the limb, pathological mobility. So in a place where there are no joints, yes, there is a mobility. It is one of the signs of a fracture. And pain during axial load. What is it, axial load? It is when we try to push in a direction of a longitudinal axis of the limb. Like if we are talking about the upper limb, we are asking a patient to make a fist and we push it. Yes, we push it. And if we are talking about lower limb, then we try to push calcaneus upward. Yes, upward. And if there is a pain, it is also one of the signs of a fracture. So that's what we have to know. Classification of fractures. So according to the mechanism, all the fractures are divided into three groups. This is traumatic fracture. So that is like, this is the most common, and it is like that fracture we deal with in traumatology. It is due to sustained trauma, like fractures caused by a fall, a road traffic accident, fight, etc. This is traumatic fracture. There are pathologic fractures which are caused by concomitant disease, such as osteoporosis, bone cancer, osteomyelitis. Like we know that in elder women after 50 years old, there is osteoporosis due to the menopause. Level of calcium in the bones falls down and density of the bones decreases, and that's why any even small trauma, any small damage may cause fracture. In those cases in which in young people such fracture wouldn't occur. And so yes, bone cancer and osteomyelitis, it can also be the cause of pathologic fracture. Periprosthetic fracture is a fracture at the point of mechanical weakness at the end of the implant. So we understand, yes, like implant is dense, bone is not as dense as an implant, and so at the place of their contact, periprosthetic fracture can also occur. So these are three types of fractures according to the mechanism of trauma. Then, according to the soft tissue involvement, there are closed fractures when there is no injury of soft tissues, and there is open or compound fracture when ends of the bone can be visible outside of the skin surface. Yes, so these are open or compound fractures. According to the presence of displacement, there are non-displaced and displaced fracture. Well, to be honest, there are no absolutely non-displaced fractures. Always there is a small displacement, but just it is either clinically, it can be either clinically significant or not. So in case of displaced fractures, we mean those which require reposition. Yes, reposition. So in those fractures which require special procedure to return the ends of the bones to their places. These are displaced fractures. So, and what are the types of displacement of bone fragments? So here you can see it can be lateral or translated displacement when a line drawn down from the center of the bone is not continuous. Yes, like there is a step at the fracture site. So this is lateral displacement. Then there is displacement along the length. It can be shortening, like in this case, or it can be lengthening, like in this case, or it can be wedge, when one end of the bone is inserted into the other end of the bone, like there is a very strong compression. And these types of displacement, they are caused by the contraction of adjacent muscles. Depending on the fact which muscles are stronger, it can be shortening or lengthening. Yes, so that is the mechanism of such displacement. There is also angular displacement when axes of bone fragments form an angle at the point of the fracture. And there is rotation or peripheral displacement that is caused by a rotation of one of the bone fragments along the longitudinal axis. So, like, again, it is due to the muscles, yes? Like one end of the bone stays and the other end of the bone rotates around it. That will be rotation displacement. All of these types of displacement, it's obviously, they require a reposition. And yes, we can say, now we must say that actually all of these types of displacement, they can be anatomically justified. So actually we can predict displacement if, again, we know anatomy. Yes, so now we will prove it. So in case of humerus fractures, in a case of humerus diaphysis fracture, displacement of bone fragments will depend where the line of fracture passes above or below the insertion of the deltoid muscle. So look, we know that deltoid muscle is the main abductor of the upper arm in the shoulder joint, yes? So if the line of the fracture is below the insertion of the deltoid muscle, then central end or proximal end of the bone, it will be abducted, like it will be located laterally to the distal end of the bone, like you can see in this picture. If deltoid muscle, if insertion of deltoid muscle is located lower than fracture line, then due to the tension of adductor muscles, which are like muscles of another muscles of shoulder girdle, yes, like it is infraspinous and subscapular muscle, yes, then central end will be displaced medially, will be adducted in relation to the distal end. Yes, so it's obviously. In case of forearm fractures, displacement of bone fragments will depend whether the line of fracture is located proximally or distally from the insertion of musculus pronator teres. So here you can see, here we will deal with rotation displacement. So if fracture line is located above the insertion of musculus pronator teres, then only supinator muscle will be inserted to the radius, yes, and so central end will be supinated. And two pronatus will be inserted to distal end of the bone, like pronata teres and pronata quadratus. So the distal end of the bone will be extremely pronated. Yes, so one will be supinated, proximal end, and distal end will be pronated. If pronata teres muscle is inserted to the central end, like line of the fracture is below the insertion of musculus pronata teres, then both of them will be slightly pronated, there will be not such a severe displacement as in this case. In this case, displacement will be much more significant than here. In case of femur fractures, specific feature of femur fractures is a shortening of the limb. It's always. It is due to the strong muscles which originate from the pelvis and insert in the leg. So you know there are many muscles, and actually all of them, yes, muscles of the thigh, nearly all of them, let's say so. They start from the pelvis, they insert it to the leg, and that's why in case of femur fracture, they will always pull distal end of the femur closer to the pelvis, and then that's why it will be shortening of the limb. In case of fracture in both leg bones, in proximal 1/3, central bone fragment gets displaced significantly anteriorly due to the tension of musculus quadriceps femoris. So we know, yes, that all the bellies of musculus quadriceps femoris, they continue into the patella ligament, they surround the patella, and then they are inserted to the tibia. And so it is a very strong flexor of the thigh and extensor of the leg. And so peripheral bone fragment is also displaced slightly anteriorly, but it is located behind the central one. So it will be always so. In case of the fracture in both leg bones in proximal 1/3. And this is very common fracture in car accident. Yes, when there is a pedestrian, he crosses the street and car is going, and like this is, what is it, anterior part of the car enters the legs of this person. So usually there will be this such type of fracture of the leg. Okay, so what else we have to say? We should discuss stages of osteoreparation or bone healing. Knowing this will allow us to understand why such a long immobilization is required in case of fractures. So first of all, right after the fracture, the first stage of bone healing, it is hematoma between ends of the bone. And hematoma, no, like you understand, hematoma is just blood. Yes, so it is just a liquid, coagulated blood, and it is very mobile, like its mobility is 100%. That's why to go to the other stage of bone healing, we need complete immobilization first. Otherwise, we will have some complications of the fractures, which we will discuss later. And so this stage of hematoma, it lasts for 1 week. Then fibrocartilaginous callus starts to be formed after 2 or 3 weeks after the fracture. But still it is very mobile. So mobility of fibrocartilaginous callus is 30%. The next, after 4 weeks, only after 4 weeks of fracture, so from 4 to 16 weeks of the fracture, there is an osseous callus. So callus, it is a new tissue that is formed in the place of the fracture. And so here, it's rather stable. So mobility of osseous callus is about 2%. That's why usually the minimal time of immobilization in different types of fractures, it is about 1 month. Yes, no, so in children it can be a little bit shorter. In elder people it is definitely longer, but usually in average it is about 1 month. And so as the last stage, that starts from the 17 weeks of the fracture, it is remodeling. So bony tissue is actually the only tissue that is not substituted by connective tissue. So after a definite time, after 3 or 4 months, we actually will not see the line of the fracture because it's not a scar, it is a normal bone. And that is the main difference between bony tissue and all the other types of tissues in our body. So bony tissue is absolutely undergoes an absolute restoration. And so, yes, we also have to understand what is actually bony callus. So we discussed it at the first year, yes, how exactly bone is formed, that there are osteoblasts and osteoclasts, and you definitely still remember it. How can you forget it? So, and there are different, several types of bony callus. So the most perfect case, when there is absolutely no mobility between bone ends, it is intermediate callus. It is just when, this is medullary cavity, and this is bony substance, yes, spongy and compact, when bony callus is formed just between this compact and spongy substance of the bone. But actually such a callus, like it is perfect, and nearly it never goes like that. There is also endosteal callus. Endosteal callus, it's here, like that grows under the endosteum, under the internal lining of the bone. Yes, that lining of medullary cavity. There is periosteal callus that grows under the periosteum, and there is paraosteal callus that grows in the soft tissues that surround the bone. Paraosteal callus, it is pathological condition. It is formed when there was a large injury of soft tissues around the bone, by the bone ends, probably, yes. And so this hematoma should be substituted by connective tissue. And when osteoblasts go there, they start working and they form also bony callus. And so this bony callus is pathological, once again I'm telling you, and it may cause compressions of some structures. Like at our practical classes, we discussed in case of compression of the radial nerve, yes, after the fracture of the humerus in middle 1/3. So with the time, these types, endosteal and periosteal callus, they will disappear after the remodeling. But this paraosteal callus, it will stay, and it, in some cases, in many cases, it requires surgical treatment. So these are types of bony callus. Which surgeries are performed in the bones? So it is, as always, osteotomy. I hope now you understand from the name what is this surgery about. Resection of the bone, osteosynthesis, and osteoplasty. These are 4 main types of surgeries on the bones. We'll discuss some more at the end, but these are 4 main types. So we'll start with osteotomy. Osteotomy, like it is obviously osteon bone, toma dissection. It is a dissection of the bone. It is usually performed by 2 instruments. We saw them at our surgical museum. It is osteotome or chisel. So they are very similar, these instruments. The difference is just in the end. Like osteotome, it is acute in the middle and then it becomes dilated, yes. And chisel, it is acute from one side, like one side, acute, and then it gets dilated from the other side. So here you can see sagittal section through the osteotome and chisel. Both of these instruments are used for osteotomy. So certainly you see there is another end of this instrument, like you put the chisel or osteotome on the bone and you take a hammer and you start beating, yes, and that's how you perform a dissection of the bone. So what are the indications for osteotomy? Correction of deformities of bone diaphysis. in case of angular, rotation, or displacement along the width and length. No, so usually it happens, no, yes, it can be innate, but it can usually happens after a wrong healing of the fractures. Wrong healing of the fractures, we'll talk about it later, it is known as malunion. In English literature, it is known as malunion. So then correction of deformities of metaphysis of long bones after the wrong healing again of epimetaphyseal fractures and some systemic diseases, like arthritis, yes, arthrosis, arthrogenic contractures, and also elongation and shortening of the limbs. Well, yes, so in aesthetic medicine, yes, sometimes it is also used in plastic surgery. So there are different types of osteotomy. Transverse, here you can see it, then oblique, it depends on the direction of dissection of the bone. Z-shaped, you see Z-shaped osteotomy can help us to elongate the bone, yes, to increase the length of the bone. Segmental osteotomy by great Russian surgeon Bogaraz. Arcuate, it is to remove angular displacement, or maybe vice versa, to create it if it is necessary. Then wedge-shaped osteotomy, and special osteotomy by Boychev. So what are the requirements for surgical approaches for osteotomies? So surgical approach should correspond scope of operation. So principle of sufficiency. Actually, this principle works everywhere in surgery. Approach shouldn't be, approach should be enough wide to provide a proper function of a surgeon in the wound, and it should be enough small to provide fast recovery. So this is principle of sufficiency. Dissection of soft tissues should be performed out of projectional lines of neurovascular bundles. So it's obviously, yes, we do not need to perform any interventions on the nerves and vessels, so we should try to avoid them. It's necessary to put a roller on the corresponding segment of the limb. So it's physics, yes, it's clearly. If you do not put a roller, if you start beating on the bone and under the bone there is nothing, then this incision will spread to those places where there is a support. That's why you should put a support right under the place where you are performing osteotomy. Yes, it's clear. And this is a hammer which you use to beat osteotomy. So there are different types of osteotomy, here you can see osteotomy scalene prolongans, that was invented by a great Russian surgeon, Khahutov, in 1962. So here it is used for elongation, prolongans, for elongation of the limb. So surgeons perform step-shaped dissection of a diaphysis. They perform it by chisel or osteotome, and after that, the ends are connected by means of bone suture. This method causes a significant elongation of the limb segment. So I want to mention, I want to draw your attention that many of these surgeries, like this one, for example, they are interesting for us just historically, because nowadays we have much more contemporary and comfortable methods. But anyway, we have to know how our ancestors, how our great surgeon dealt with such problems in the past. Opposite surgery, it is osteotomy scalene abrevens. When we are performing step-shaped dissection and one part is removed by chisel or osteotome, and the two ends are connected again by bone suture, and it causes shortening of the limb segment. segmental osteotomy of the femur by Bagaras. Here you can see it. This osteotomy is used to remove deformity of the femur. Yes. So a dissection of soft tissues is performed along the lateral surface of the thigh. Why? It's clear, yes, because anteromedially there are main neurovascular bundles. Yes, that's why we are going laterally. So femur is exposed and dissected by a sharp osteotome, chisel, or electric saw in 2-4 places, depending on the degree of deformity. And then dissection of the bone starts from its distal end by parallel incisions on the distance 4-5 centimeters from each other. Limb is extracted and placed in a correct position. And then a metallic rod, here you can see it, is introduced into the medullary cavity for the fixation. And then wound is stitched and skeletal traction is applied with a load 10 to 50 kilo. Location of bone fragments is controlled by X-ray. What is skeletal traction? I hope you studied it in general surgery. In one of the next slides, you will see it. What is it? No, so it's like we attach the weight, the cargo, something, to the end of the limb, and we pull it in a correct direction. This is known as skeletal traction. I will show you later. Transverse segmental osteotomy by Springer. Springer he's from Czech Republic, Czech surgeon. So again, in case of a deformity of the limb, subperiosteal dissection of bone diaphysis is performed into segments 1 centimeter length. So subperiosteal, it means that we will talk also about it later. We dissect periosteum, we remove it laterally from the wound, and we do not involve periosteum to our surgery, because we need to preserve periosteum, because as you remember, periosteum provides growth of the bone in width. Yes, increases bone width. So limb is stretched and bone fragments are put into an even periosteal covering, and periosteum is sutured and limb gets immobilized. So yes, the sense is that we remove deformity by cutting the bone into small pieces and putting them correctly in a proper position. Okay, the other operation, it is a resection of the bone. As any resection, it is removal of the part. In this case, it is a removal of the bone part. Here you can see different types of resection. So why do we perform resections of the bone? In case of pathological processes in the bone, like it can be tumors, it can be post-traumatic osteomyelitis. So osteomyelitis, it's clear. Yes, it is purulent lesion of the bone involving medulla, yes, involving bone marrow. It is osteomyelitis. Then the other indication for resection of the bone, it is treatment of the bone fragments in a case of false joints and non-unions. Non-union, it is another term that means fractures that fail to heal. Probably there was a very big gap between the bones, or maybe some other reasons, but time passed, fractures like the ends of the bone did not connect, and it caused formation of false joints. False joint, it is, or pseudoarthrosis, another name. It is a mobile, like a gap between bone ends after the fracture that is passively mobile. Certainly not actively, because there are no special muscles, but it is passively mobile. So this is false joint. The other indication for the resection of the bone, it is harvesting of bone autografts, like we saw it at our surgical museum. Yes, some bones can be used as autografts, like fibula, for example. We take it sometimes in some other bones. So shortening of the limb, it is in plastic surgery, yes, and elimination of the limbs deformities. So these are the main indications for the resection of the bone. There are different types of bone resection. So marginal or partial resection, it is a removal of the bone fragment without a damage of its anatomical continuity. So usually it is used for biopsy. For example, we need to take some part of the bone as a sample to perform histological and some other examinations, yes, to identify what is this, is it a benign or malignant tumor, and to choose our management in future, yes. So, or we can use it to harvest autograft. Like, as I told you, we can use tibia, or we can use part of fibula, or we can use part of tibia, like in this diagram you can see it, or we can take a wing of ilium as an autograft for the rib, to substitute the rib. Segmental or expanded resection, it is accompanied by a damage of bone continuity. Like in this case, two ends are formed, proximal and distal, and we need to connect them somehow. In case of partial resection, there are no ends, we just take it, and that is all. And here we need to connect two ends together after that. Yes, according to the way of periosteum treatment, resection, as well as osteotomy, actually, they can be subperiosteal or transperiosteal. So subperiosteal resection, it is certainly preferable when periosteum is removed from the resected bone fragment. What does it mean? Maybe it's not quite correctly written. It means that we do not involve the periosteum into our interventions. Like, anyway, we have to dissect periosteum, and then we take these special instruments, which we also saw at our surgical museum, like Parabef retractors, yes. And we pull periosteum from the operational field, like we remove it laterally to both sides from the operational field. And then we perform resection of the bone, and then we connect periosteum, and that is all. We need, once again, I'm telling you, to preserve periosteum, because without periosteum, healing of the bone will be impossible. Because periosteum, it is a source of osteoblasts, yes? And transperiosteal resection, when bone fragment is resected with periosteum. Like, we just do not pay attention onto the layers of the bone. We are just taking osteotome, cut from one side and cut from another side, then we remove this fragment, and then we connect the other fragments. So it is worse, because periosteum is contractable tissue, yes, it will go away from the wound, from the line of the resection, and it will impair prognosis, yes, it will impair recovery. But sometimes we are forced to do it, for example, in case of tuberculosis or malignant tumors, when we have to dissect within healthy tissues, yes, within healthy tissues, when we need to be sure that all the pathological tissues are removed, then we choose transperiosteal resection. So here in this diagram, you can see subperiosteal resection. Like, we dissected the periosteum, and then this is jiggly saw, yes, so we are sewing it, the bone without periosteum, and then we'll stitch it. According to the time factor, all the resections are divided into final with an irrevocable removal of bone fragment. It means we removed it and that is all. Yes, like replacement of mandible defect by fibula fragment. Yes, so we took fibula because we need to place it instead of mandible. Yes, and so it will never return back. It is final resection. And temporary resection, resection with a returning of resected fragment back into the body after an appropriate treatment. Like we are taking a fragment, for example, of the rib. We will talk about it when we study surgeries in the thoracic cavity. We resect the rib. We remove it because we need to reach organs of thoracic cavity. We did everything we wanted, then we put the rib back, and that is all. The same when we study surgeries in the skull. Yes, we will discuss trepanations, and one of types of trepanations, it is osteoplastic, when again we make a defect in the skull bone because we need to perform a surgery on the brain. We remove it, perform all the surgery we need, and then we put it back, so it was temporary resection. Yes. Okay. So osteosynthesis. It is again Greek term. Osteon means bone, and synthesis means connection. It is an operative connection of bone fragments by means of metallic constructions which provide fixation of the fragments after reposition to create favorable conditions for healing of the bone with the restoration of an integrity and function of the bone. This is definition that you have to learn. So we'll discuss this definition as the practical classes. Probably it is too long, but it includes all the features of osteosynthesis. So what are the indications for osteosynthesis? Not any fracture ends with osteosynthesis. Yes, sometimes we just perform reposition and apply gypsum bandage and send a person home and tell him you will come after 4 weeks. But sometimes we have to use osteosynthesis. So in which cases? First of all, it is in case of acute fractures. Acute fracture means fresh fracture, like it has just happened. Yes, when conservative treatment is not efficient. When, for example, fracture is intra or periarticular, and when it is comminuted. Comminuted fracture means that fracture that has very many bone fragments. Not then when the bone is broken not into 2 parts, when it is broken into many parts, and it won't be healed correctly without special devices. Non-union fractures, like it's already not acute fracture, like time passed, we were waiting for its healing, it was not healed. So fractures that fail to heal, it is another indication for osteosynthesis. Malunion fractures, when fracture was healed, but it was healed wrong, probably reposition was wrong, something went wrong, and also we need apply, like we need to try something else, yes, to help this person. False joints, I have already told you. Yes, this is like another type of non-union fractures, but it was not just not healed, but also there is a mobility between the ends of the bone. Yes, and so these are false joints. Fixation of bone fragments after osteotomy and other bone surgeries. And elongation of the limb. Elongation of the limb is another indication for osteosynthesis. So classification of osteosynthesis. Bone suture. So I want to tell you, in some books, bone suture does not belong to osteosynthesis. It's like a separate surgery. No, okay, it's fine. We'll discuss it at our practical classes. Then there is extramedullary osteosynthesis, when devices for connection of the bones are located out of the medullary cavity. Intramedullary osteosynthesis, when devices are located inside the medullary cavity. And osteosynthesis by means of external fixators, it is compression distraction osteosynthesis, when this device is located outside, like just some parts pass through the bone, but the whole device is located outside of the body. We will look at it today. It is actually, you saw it at our surgical museum also, it is Elizarov apparatus that is known all over the world. all over the world. It's very popular. It was invented by a great Russian surgeon, Gavrilo Arkadyevich Yelizarov. So what are the main principles of osteosynthesis? So Sumit Tanwar today wants to go on air for 5 times already. It's not compulsory, Sumit Tanwar, please. It's a lecture, or 6th time. Main principles of osteosynthesis. First of all, there must be anatomical approximation of bone fragments. So fragments should be matched very precisely to each other. Then stable fixation of bone fragments to prevent formation of false joints. A traumatic surgical technique. A traumatic surgical technique allows us to prevent complications in postoperative period. Joints adjacent to the fracture are freely mobile after the surgical treatment. Like I think you have studied it in your disaster medicine subject, yes? When we apply, or maybe in surgery, I don't know where exactly you have to study it, like when we apply a gypsum bandage, there is a special rule that at least 2 joints adjacent to the broken limb, they should be fixed, yes? And it actually makes a person to be invalid for a definite time. In case of osteosynthesis, there is no need for that. After the wound healing, actually this person is absolutely healthy and he can perform any movements with his limb. Like it's for the patient, it's much more comfortable, if not to consider that repeated surgery is required to remove this device, yes, from his body after the complete recovery. Metals used for osteosynthesis shouldn't cause immune reaction. So certainly like suture material, so anything we put inside human body shouldn't cause immune reaction. Otherwise, we shouldn't put it into human body, yes? So, and bone should repair by primary bone intention. Like about primary and secondary intention we have already said, yes? And if wound is healed with primary bone intention, it is faster and there is a very small scar. And if it is secondary, then there will be always a connective tissue between the edges of the wound. So it's not so effective, it's not so reliable. Okay, so first bone suture or osteography. Raphy means suture, osteo means bone, it's clear, yes? So requirements for bone suture. First, it is exact reposition of bone fragments, no, actually like in all the types of osteosynthesis. Then proper approximation of bone fragments, absence of diastasis between bone fragments, so there must be no gaps between bone fragments. Secure fixation of bone fragments by sutures for the whole period of treatment, plaster or gypsum immobilization until the complete consolidation of bone callus. Preservation of periosteum in the zone of sutures, prevention of osteomyelitis development in postoperative period. So one of the reasons of osteomyelitis is an impaired blood supply, yes, and so that's why we should preserve periosteum to prevent development of osteomyelitis. Well, certainly for the bone suture, we have discussed it at our first class, I think. Special suture materials are used because bone is very firm, solid, yes. And so usually stainless steel wire is used, or titanium or tantalum. Chromic catgut can also be used. And if we talk about synthetic threads, it can be nylon or lethylene or dacron, but certainly they must have a rather large diameter. Like when we were talking about vessels, we said the diameter should be very small. But here in the bone, it's vice versa. Diameter should be large to be very firm, to not to be broken, yes, because load is very high. Which sutures are used, are applied in the bone? So circular nodular suture, not just it's a simple interrupted suture, yes. Then U-shaped suture. Here you can see it in this diagram, U-shaped suture. Then cross-shaped suture, trapezium-shaped, and combined suture is also used, like in this, for example, diagram. Well, it's small, but here we can see superiorly it is circular suture, and then inferiorly we can see there is a special, I think it is, no, like metallic stapler. Yes, metallic stapler was used. This is combined suture. So what are the advantages and disadvantages of bone sutures? Advantages are simplicity and reliability, like anyone can do it, not any special equipment is required, and it's rather reliable, it's more reliable, let's say, so that just gypsum immobilization, yes, and fast application. But there are many disadvantages of bone suture. Like if plane of the suture is not perpendicular to the line of fracture, deviation of bone fragments with the formation of false joint is impossible. Like if it's not absolutely perpendicular, then if it is like that, yes, then automatically margins of the ends of the bone will be pulled to different sides. No, like there will be displacement after a suturing and formation of false joint. Traumatization of periosteum and local disruption of bone blood supply. No, so it's clear, yes, why? Because we insert the needle, we pass through the periosteum, and when we tie a knot, we compress periosteum. No, so certainly it is unavoidable disruption of blood supply. And possibility of wedge displacement in case of an uneven distribution of force. Like if we tie a knot too hard, if we try too much, yes, then ends of the bone, they will enter each other, and then there will be wedge displacement. It's also not quite good. So these are the main disadvantages of bone suture. Here you can see different devices which we can use for osteosynthesis. Now, so this, you can see different plates, compression plate, this one, and the standard plate, yes. So these plates are applied for extramedullary osteosynthesis. No, it's obviously, it's clear, yes. Like we attach one end of the plate to one end of the bone, the other end of the plate to the other end of the bone, and we fix it with screws. No, it's like when there is a cupboard. Yes, it's obviously when there is a cupboard and there is a door, you need to fix the door to the cupboard. You use something like that. Yes, yes. So for intramedullary osteosynthesis, the other devices are used, such as here you can see intramedullary nail, very popular, and then rush pin and Denham pin and compression hip screw. And here, for example, yes, again, you can see intramedullary nail in case of the fracture of the femur. And this is Kirschner wire. Kirschner wire that was invented by a German surgeon, great German surgeon. This is used in case of fracture of small bones, like bones of the hand, for example. And certainly you understand that these are all metals, and certainly they will be visible in the X-ray pictures. I hope at our practical classes we will see some of them. Two approaches of wire introduction are distinguished. So not only wire, anything, any of these intramedullary devices can be inserted, can be introduced by two ways. So closed method, when it is introduced away from a fracture place through a small incision. And then open method, when fracture zone gets exposed, bone fragments are repositioned, like returned to their places, and the rod is introduced into the medullary cavity. This is open. fixators can be introduced. Like here we are talking about surgical approaches. Yes, we can do it by open way, like when there will be a big wound and it will be in the place of the fracture, and closed way when it is far from the fracture. And we can introduce fixators by 3 ways. Antegrade, when we move in distal direction, from proximal to distal, like distally. It can be performed by open and closed approach. So here you can see it is closed approach, closed locked femoral intramedullary nailing. So that's we are trying to insert this intramedullary nail to the femur, to the medullary cavity of the femur, due to the fracture in its middle 1/3. Yes, here, by the way, in this picture, you also can see skeletal traction. So through the condyles of the tibia, special pins were introduced, and to this pins, special device was attached, and at the end of this device, there is a weight, there is something heavy, yes, and it is pulled to provide reposition, because, as we have already said at the beginning of the lecture, in case of the femur fractures, always there will be displacement with the shortening of the limb. So we perform the reposition, we are providing skeletal traction, and then through the closed approach, we perform antegrade introduction of fixator. I hope it's clear. The other way, it is retrograde. It can be performed only by open approach. So how to do it? Retrograde. We are taking proximal end of the bone, and into the medullary cavity, from the line of the fracture, we insert this device, whatever we use, rod, intramedullary nail, something, any intramedullary device. And by this device, we are actually making a hole in the proximal epiphysis of the femur. Then we perform reposition. Yes, you can see it. Perform reposition, and then we start to push it backward, to push it inferiorly downward. And in this way, we also connect two ends of the bone. This is retrograde. So because first we are going backward, and only after that we are returning. And along the conductor can be performed by open and closed approach. No, so it's when first we introduce special conductor, special cannula into the medullary cavity, and along this cannula we introduce this fixator. No, it must be special fixator, certainly, like memory shape fixator with a memory shape, because it must be first flexible to pass along this cannula, yes, and then when it is installed into its position, it should become solid. Now such fixators also exist. So extramedullary osteosynthesis. So different, as I have already told you, different plates are used, fixed by screws. Here you can see it, for example, in case of radius fracture. Yes, they can be different. What are the stages of extramedullary osteosynthesis? So first, it is surgical approach to bone fragments. It's obviously, yes, that corresponds to the sizes of fixator. Then precise matching of bone fragments in an appropriate position. Fixation of the plate by screws that pass through both cortical layers of the bone fragment. Like fixation of the plate to one end of the bone, and then fixation of the plate to another bone fragment after the compression of the fracture zone by special device, and so then exit of surgery. No, it's clear. Yes, it's easy. Yes, and the other way of osteosynthesis, the other method, it is osteosynthesis by external fixator or compression distraction osteosynthesis. It is performed by special devices, as I have already told you, Ilizarov apparatus or Gudushauri apparatus. And Installation of such devices, compression distraction device, consists of the following stages. So first, we should insert these pins. Yes, here you can see pins or spokes, we can say, transosteal conduction of the pins, then fixation of these pins in arches or circles, like peripheral ends of the pin should be fixed by these arches or circles, and then installation of connecting rods. So between arches or circles, there must be also connecting rods around which the circles will rotate and change their position, like they will approach each other or they will go further, they will become distant from each other. So the main advantages of the method, it is stable, very stable fixation of bone fragments and dynamic possibility to manage their location, to change their location. Like we also saw it at our surgical museum, yes? Like first we installed circles, like let it be 10 centimeters from each other. If we want to compress, we approach it, yes? First we approach for the recovery of the bone, for the formation of the fibrocartilaginous callus, yes? And then we start to dilate, to increase distance between the circles, because we need to restore the length of the bone. It should correspond to the length of another bone if we are talking about the limb, yes? Like the length of tibia in the right leg to correspond the length of tibia in the left leg, because we shouldn't make our patient to be invalid. So there are special rules of pins introduction. We will also discuss it at our classes. So pins should be introduced from the sides of neurovascular bundles location, and the end of every pin should be very sharp. So it's obviously, yes, why we start from the side of neurovascular bundles location, because we should have a visual control not to damage them. Number of pin turns during bone drilling should be small. While pin passes through flexor muscles, limb should be extended, because in a position of extension, flexor muscles are stretched, yes? While pin passes through extensor muscles, a limb should be flexed. So again, in a flexion position, extensor muscles, they are maximally stretched. If we piece these muscles in such a maximally stretched position, then any mobility of these muscles will be possible. Before piecing the skin, it should be maximally relocated to the side opposite to the future relocation of the apparatus circle. Like if we are planning, for example, to compress, then we should pull the skin maximally laterally, yes? If we are planning to distract later, then we pull the skin maximally medially, because we need some extra tissue, because after that we'll try to pull it in the opposite direction. Yes? Is it clear? I hope you understand me. That was about osteosynthesis. Osteoplasty or bone grafting is also used. So 3 types of grafts are used in osteoplasty. These are autografts. So when we take some bone from the same patient, yes, and we just replace it, relocate it. Allografts or homografts, when we take the bone from another person, from another human, let's say so, from the dead person, even not long ago dead, but recently dead, yes, like donor. And xenografts or heterografts, like when we take bone from the animals, from another species. So nowadays it's not very popular. And also there are synthetic grafts. We will discuss it and we will even see it at our practical classes. And there are 3 types of bone grafting. There is free bone grafting, when we just take the bone and put it into absolutely another place. There is bone grafting by sliding graft, what is it we'll discuss now. And there is bone transplantation on the nourishing leg, when we, or non-free bone transplantation, when we take a bone and we do not deprive it by blood supply. So when we transplant the bone somewhere very close to its previous location, and so it has the same blood supply as it had before transplantation. So what are the indications for bone grafting? Delayed unions. It is another term that is used in English literature. It is slow healing of fractures. When fractures are healed but very slowly, then we have to perform bone grafting. False joints, bone defects, then bone grafting is used in arthrodesis. We will talk about it. Stabilizing surgeries on the vertebral column, anterior and posterior spondylodesis. So when we need to provide immobility of some parts of vertebral column due to some diseases, we also take some part of the bone and we fix it between two vertebrae, and it will be anterior on the anterior surfaces, or maybe on the posterior surfaces in the arches. It will be anterior or posterior spondylodesis. Replacement of joints segments, and the other cases. So this is bone grafting by sliding graft that was actually invented by a great Russian surgeon Khahutov again, but in all the literature, English literature, it is known as osteoplasty by Olby. So I just inform you that in English literature you will find it as osteoplasty by Olby. So what's the sense? Yes, two plate-shaped grafts are dissected by electric saw in both ends of the bone. On the longer part, it will be, here you can see it, 12 to 15 centimeters, and on the shorter part, it will be 3 to 5 centimeters. And then we take them out. Yes, so we have two plates. And after the removal of plates, a small groove is formed on the bone surface. And then we just take these two plates and we just replace them. So now shorter one is in the longer part and longer one is in the shorter part. And a longer graft, here you can see it, is placed in such a way that it covers a line of fracture. So now in the fracture line, there is bony tissue. Yes, so there is no more fracture. A shorter graft is placed into the defect that is formed after relocation of a longer graft. And grafts are fixed by catgut circular sutures, and after the surgery, gypsum bandage is applied until the complete healing of the fracture. So this is bone grafting by sliding graft. Yes, very interesting surgery. Intramedullary bone grafting is also used, but usually it is used in pediatrics, in children. The sense of it is in the introduction of bone graft into the medullary cavity of both bone fragments. Like in adult, we use the same, but with special metallic devices. Yes, intramedullary devices. In children, we can use the bone. Allografts as well as autografts are used. And after the disconnection of bone fragments, at first, bone graft is introduced into the medullary cavity of longer bone fragment, then into the shorter. Yes, and so then wound is stitched. Yes. So yes, the main advantage of such a surgery, it is that there is no need in a repeated surgery for the removal of metallic construction. I have told you about it before. Yes, in case of osteosynthesis, we always need a repeated surgery to remove this device because it is metallic. Yes, it's any way it is something foreign. And so disadvantages are insufficient solidity of the graft causes a long immobilization, and weak stimulation of reparative regeneration makes this method inefficient in treatment of false joints. In case of false joints, we will not use this method, because it doesn't stimulate reparation of the bone very much. Also, we have to say that intraosseous anesthesia is also used in case of limb surgery for injuries, fractures, osteomyelitis. So the principle of intraosseous anesthesia is that the anesthetic, being introduced into the spongy substance of the bone, usually in the epiphysis, is spread to the soft tissue through the veins, having a good connection with the interosseous veins. No, so due to the anastomosis, yes? And that's why intraosseous anesthesia can be referred to one of the varieties of intravenous anesthesia. What is the advantage? Why not to just introduce the anesthetic into the vein? Because from the vein, it will go to the systemic circulation very fast. And here it eliminates very slowly. Yes, that's why it is used. And so here you can see it, stages of intraosseous anesthesia. First, it is anesthesia of soft tissues, then bone puncture, like in Silzinger technique, as always, yes. So we remove the stroke or mandren, and then we introduce special anesthetic solution, Novocaine, lidocaine, whatever, yes. And one more thing, it is operations at osteomyelitis of tubular bones. So osteomyelitis is a purulent lesion of all the components of the bone, periosteum, compact bone, and bone marrow. Yes, and actually you studied it in surgery. I think that there are different types of sequesters. Depending on their location, they can be cortical, total, central, or terminal. And the surgery for removal of these sequesters, these necrotized parts, it is sequestrectomy. For this sequestrectomy, special instrument is used. It is Walkman spoon, yes, Walkman bone curette, we can say so. Yes, so as always, there is surgical approach. We should expose the bone, then we should make a dissection of periosteum longitudinally and retract the wound by Farabefra spetus. Then we will destroy the anterior wall of sequester cavity, and sequesters should be removed with bone curette or forceps. And we should remove them from all the walls of the cavity by Walkman spoon till the appearance of bleeding, preventing the damage of the epiphysis and growth plate. Yes, because growth plate provides growth of the bone in the length. Yes, increases the length of the bone. In case of chronic osteomyelitis, always very large cavities are formed, and that's why sometimes we have to fill them in with something. So we can close the questral cavity with the help of special filling substances, and also we can use musculoplasty that promotes the formation of anastomosis with the vessels of periosteum and resorption from osteomyelitic cavity of necrotic detritus. And so here you can see it, like into this cavity, muscle was placed. Here we had to watch some video, but we have no time watching a video. I will send it to you to the chat. So we also have to discuss today basic principles of surgeries on joints. So again, as always, there is arthrotomy. It is surgery aimed to open articular cavity. And so indications, it is primary surgical treatment in case of any wound, or removal of foreign particles if they are, drainage of joints in case of purulent processes. So depending on the aim of surgery, arthrotomy can be a surgical procedure. For example, for treatment of empyema, this purulent process in the joint, yes, or removal of foreign body. In this case, we just perform arthrotomy, and that is all, yes? Or just a part of a surgical approach for subsequent resection of the joint, for example. Surgical approaches to the joints must be anatomical without damaging periarticular structures and ligaments of the joints. So here you can see arthrotomy of the knee joint. We can see that we should be very careful not to damage anything. Like we perform lateral dissection, we shouldn't dissect collateral ligaments, yes. And then when we open the joint, yes, we are forced to dissect patellar ligament, but after that we have to stitch it, and we should be aware not to damage anything else. And certainly posterior approach is not used because there are very many muscles from posterior side, and so it's better to prefer anterior approach in case of knee joint surgery. Resection of the joint. It is surgery of partial or complete removal of articular ends of the bones with cartilages and synovial capsule. So indications: as an independent surgery in case of a purulent alterations of articular cartilages and tuberculosis, and as a preliminary intervention in case of arthrodesis, arthroplasty, or endoprosthetics. So yes, no, we'll talk about it right now in a few seconds. Okay, stages of joint resection. So first, arthrotomy, to create a wide approach to articular ends of the bones. Then removal of pathologically changed fragment, so whatever part, any part of articular surface that is damaged, we should remove it. Then immobilization of the limb by means of gypsum bandage, and then rehabilitation of the joint, like special physical procedures, some exercises, so it's a very long process. Arthroplasty, surgery aimed for restoration of the shape and function of the joint in case of its immobility or creation of conditions that prevent formation of ankylosis after joint resection. Ankylosis, it is a condition of an immobility in the joint. It is ankylosis. So indications for arthroplasty, it is bone and fibrous ankylosis and contracture of the joint in the young age. So what are the stages? It's again arthrotomy, disconnection of articular surfaces along its cavity, processing of bone ends, creation of the shape that is close to normal shape of the joint, and then interposition of articular surfaces by means of a layers from fascia lata. So we are taking fascia lata from the lower limb, yes, some parts, and we put it. So nowadays certainly there are special synthetic material, like we needed to prevent formation of adhesions, yes, to improve gliding, to prevent friction, yes, and then also immobilization of the limb by means of gypsum bandage or skeletal traction, and then rehabilitation of the joint. So yes, I promised you to show this. Yes, that's in case of femur, I guess, and leg fracture, both of them. Like in case of femur fracture, this device is used. Like, no, I guess here it is just the leg. In case of femur fracture, we conduct the pin through the condyles of femur. Yes, here we can see it passes through the proximal end of the tibia, and so after that, at the end of this device there is something heavy, yes, and the other is attached to the calcaneus, and it also ends with a weight, and so it provides immobility, and it provides traction, and it prevents another replacement in case of fracture or after the surgery, for example. Yes, arthrolysis is the other surgery in the joint. So it is surgery aimed to create conditions for restoration of a small range of movements in the joint, like if there are adhesions between articular surfaces. Yes, for example, in case of extensive contracture of the joint. What is extensive contracture of the joint? It's when joint stays in a position of extension, like it's stuck in the position of extension. So what are the stages of the arthrolysis? It is arthrotomy as always, then dissection of adhesions, then placement of articular ends of the bones into a correct position, and then again we put fascia lata or some synthetic materials between articular surfaces to prevent formation of new adhesions. And so the last surgery, it is arthrodesis. It is surgical intervention aimed to create an artificial ankylosis, artificial immobility of the joint in an appropriate for the limb position. So indications, deformities of the joints by different etiology and their pathological mobility. And like we discussed at the previous lecture, in case, for example, of the paralysis of the deep fibular nerve, if we can do nothing, it is the symptom of its injury, it is drop foot, yes, and it is quite uncomfortable for the person to go in when foot is always dropped. That's why we perform arthrodesis. We flex the foot in the talocrural joint and we fix it in this position. So there are three methods of arthrodesis: intra-articular, extra-articular, and combined. So the sense of extra-articular arthrodesis, it is creation of ankylosis without an arthrotomy by para-articular installation of OTA or Ella bone graft. And in case of intra-articular arthrodesis, we perform arthrotomy, we resect articular surfaces, match the articular ends, and immobilize, and so we wait until they join each other, fuse with each other. So here you can see anterior arthrodesis of the foot, extra-articular. When we take some part of tibia, yes, you see we took some part of tibia, we put it here between talus and the anterior surface of tibia, yes, and so excessive flexion, extension, yes, excessive extension of the foot is impossible due to the presence of such a thing, such a bony graft here, like it acts as an obstacle, yes, as a barrier. Okay, that is all I wanted to tell you for today. I will send you the video that we couldn't watch to the chat, so you will enjoy it. I hope so. Any questions? Okay, so I guess you have no questions. You are welcome. Hashem, I still do not read in Arabic. Okay, so goodbye.